Welcome, everybody. So welcome to this Ask About Asthma primary care webinar. It's fantastic to have so many people here today. We've got 99 people in the room, and I suspect people will carry on joining over the next few minutes. My name is Rosie Marsh. I am here to chair the meeting. And my background is that I'm a GP in Islington, and I'm also the NCL-ICB Children's and Young People Asthma Clinical Lead. So it's really my privilege to be here today with so many other people who are interested in the field and to learn a little bit more about some of the changes and updates and really important key bits of information that are going on in the field. What I wanted to do just before we start is to go through some housekeeping. So you'll have noted that as you've come in, you've been automatically muted and had your camera switched off. Apologies that we don't get to share your beautiful faces, but the reason for that is that it enables everybody to listen and attend to the speakers, see the slides, and also we hope that it helps you feel more confident sometimes in participating in the chat. Do feel free to put questions and information and responses in the chat. It's a really, really useful forum. My experience of being in these webinars before as a participant is that some of the most interesting things come about from really good questions that are asked. So no question is too simple. Please just pop your questions there. And if you've got good experience from your own practice that answers other questions, do feel free to put in responses or additions to other questions already there. You'll have seen as well that the recording button's been turned on. So this session is being recorded, and that's just so that we can get it out to as many people as possible who can't be here at this moment in time. All participants and people who've registered will have a follow-up email sent with a link to the recording and the slides. So fear not, you don't need to scribble everything down as we go. Okay, moving rapidly on. I mentioned myself already, but for those who've joined in the last 2 minutes, you can see my details there. So I'm Rosie Marsh, and I'm chairing today. Our speakers today are Chris Griffiths, who's a GP and Professor of Primary Care at the Centre for Applied Respiratory Research, Innovation and Implementation, and Richard Chavas, who's a consultant respiratory paediatrician at St George's Hospital. And our plan is that we'll have some short slideshow and information from each of our speakers, and then we'll have a good amount of time for questions and answers at the end. So if I can welcome Chris Griffiths first.
Hi, everyone. Great. Yeah, I'll fire away, Rosie. Yeah.
Go ahead.
Fantastic. Okay. Well, thanks for inviting me. It's great to be here. And so the first bit of this session is talking about how the new draft guidance from BTS, Sign, NICE, that's out for consultation. How is that going to affect primary care? So that's the main topic, and it's a bit of a refresher for primary care asthma as well. So next slide, please. So here's the overview. I think the top line here is that the new recommendations, I think this is a big opportunity for us all to improve asthma outcomes, which I think is a really important thing. So I would encourage everybody to try to grasp this opportunity and we can all make a difference. So I'll cover these changes in the new guidelines. What do they involve? There are changes in the diagnosis pathway that's recommended. The big change is this switch from separate inhalers to managing asthma with combination inhalers. Richard in the next talk is going to cover that, so I'll leave the details to him. A really important recommendation is nobody should be having a short-acting beta-2 agonist inhaler prescribed on its own. A lot of good reasons for that, so that's a no-no now. Control and asthma reviews are really important, and we'll touch on that. And there's an emphasis on air pollution as an important trigger for asthma in the new guidelines. So next slide, please. So why is all this important, and why is this opportunity important? Well, the answer is that asthma death rates in the UK were coming down, but in the last years they've stopped. So that is something to be concerned about. So when did they stop? Next slide, please. They stopped around 2014, and that was when the really important National Review for Asthma Deaths came in. And so you would have hoped that asthma death rates would have fallen. So this chart shows on the y-axis asthma mortality rates. The three different lines are three different groups. Green is 10 to 14 years, grey 15 to 19, and orange 20 to 24-year-olds. And you can see over the years from 1998 to 2020 that the trends were downwards, but around the last decade, they've stalled and even risen. So things are not as they should be. So next slide, please, Rosie. Jojo. So even worse, the UK ranks not just worst for asthma deaths in Europe, but we are about double the next worst country. So you can see down here the countries listed on the left, and asthma death rates in young people aged 20 to 24 along the bottom. And the green line, horrendously, is the UK, and we're about double Ireland, and way more than that for the rest of the countries in the in Europe. So this is dreadful, and we need to make a difference, and I believe we can make a difference. Next slide. Not only that is that asthma admission rates, there's a big inequalities here. If you compare the least deprived area with the most deprived area, then the most deprived area has at least double the admission rates for asthma of those in the least deprived area. So that's not right either. Next slide. So I mentioned about air pollution, an emphasis on air pollution, and most of us in London will be aware of the death of Elikasi Deborah and the fantastic campaign that her mother, Rosamond, has pursued, trying to improve things, particularly around air pollution. And I think it's sometimes the perception is, well, Elikasi Deborah had, a very severe particular, was it a peculiar type of asthma? But the important point here, I think, is that air pollution is a big factor in asthma attacks in general practice. And on the right is a paper that showing an analysis that we did in East London. So this was East London prescribing data from general practice. I think 130,000 individuals in the analysis, and it shows that just for a small increase, a 1 microgram per meter cubed increase in oxides of nitrogen, you get a 2.5% rise in oral corticosteroid prescriptions in general practice. So there doesn't have to be a big rise in oxides of nitrogen to trigger more presentations to primary care of asthma attacks. So pollution and asthma attacks is it's a primary care issue, and these people are pitching up in your surgeries. So happily, air pollution is improving in London, but this relationship is still there. Next slide. So moving on to the guidelines, let's take it in turn. This is recommendations around diagnosis in adults 17 years and over, and the big changes that they're recommending that in people where a history and examinations support a diagnosis of asthma, i.e. you are thinking, has this person got asthma? The first thing you do that's recommended is measure exhaled nitric oxide or do a blood test looking for eosinophils. And the recommendation is you can diagnose asthma if the exhaled nitric oxide is over or equal to 50 parts per billion, or the eosinophil level is higher than the lab range. Now, straight away, most of us don't have exhaled nitric oxide measurement facilities in our surgeries. But some do, and I think it's an option. There's quite a lot of controversy about the thresholds. NICE chose thresholds that they thought were probably about right, and they erred on the side of caution, such that if someone did have a level of 50 parts per billion, then that they thought was suggested that person really did have asthma. So it is an option, and some practices might want to get into that. Eosinophils, if it's above the lab normal range, there's a caveat here, because in areas where strongyloides infection, this is a worm, then this can raise the blood eosinophil level. And in an analysis we did in Tower Hamlets of 1/3 of people with raised eosinophils had positive serology for strongyloides. So eosinophils equals asthma. That's not the case. There are other things that can put up the level of blood eosinophils. Anyway, if the eosinophil level is normal, or the FeNO level is lower than that range, then you should proceed to spirometry. And if you have bronchodilator reversibility of 12% plus 200 mils from baseline, or 10% of predicted normal, then you can diagnose asthma. If it's still uncertain, then you can refer for a bronchial challenge to look for hyperresponsiveness. So that's adults. The next slide. So children aged 5 to 16, it's different again here. So the first step in someone in whom you suspect asthma is the recommendation is to measure exhaled nitric oxide. The threshold here there is different. So if that child does not reach that threshold, the recommendation is to move on to spirometry, and the thresholds are similar to adults. There, I won't read them out again. And if you still are uncertain, you haven't diagnosed because they've reached those thresholds, then a recommendation is skin prick testing to house dust mite, measuring immunoglobulin E and eosinophils. And if you reach those thresholds, IgE raised or eosinophils raised, then you can diagnose asthma. So, those caveats around eosinophils and the question about access to FeNO testing is there for children as well. So these are the recommendations. And next slide. In children under 5, this is what the guidelines said. No evidence was available for diagnostic tests in children under 5. So if you're uncertain, children under 5, difficult for them to do those tests. When they reach 5, then you should try to do the diagnostic tests that have been recommended in children 5 and over. Okay, next slide. So here's a summary of the treatment guidance changes. So I'm embarrassed, there's lots of acronyms here. I hope everybody can understand them. As I said earlier, no solo salbutamol, no solo SABA prescribing. Use the MART and AIR inhaled corticosteroid formoterol regimens. So Richard's going to talk about those. ICS, inhaled corticosteroids, recommended for all age groups, both as first-line treatment and at all stages of treatment escalation. So inhaled corticosteroids still a cornerstone of asthma treatment. These last recommendations have been around for a while. Don't prescribe a long-acting beta-2 agonist alone. Can only be prescribed with an inhaled corticosteroid. Never prescribe theophylline. I don't think anybody does prescribe that much now, but it's not an easy drug to use, not well tolerated, and it's quite dangerous as well. And then there's recommendations about offering climate conscious inhalers. it's not that the inhalers are conscious themselves. So it's about inhalers that reflect your consciousness about the climate. Next slide. So here are just some reasons why we shouldn't prescribe SABA alone. Treats the symptoms, but not the disease. You think that it's only people with severe asthma that have fatal attacks. It's not. People with mild asthma, and they can be people who are just prescribed SABA alone. If you start off at diagnosis prescribing a SABA, then people just think, well, this must be my main asthma inhaler. So that's not a good way of encouraging adherence to inhaled corticosteroids. And the last two reasons, as Richard will tell us, these new combination inhaler regimens, they really are more effective, and the evidence suggests that they cut asthma attacks and they cut admission rates, and that's really important. So no SABA prescribing alone, and move to these new combination regimes. Next slide, please. So, is this a particular problem for adolescents and young adults? Just solo use of SABA and over-reliance on SABA? I think there's some evidence that it is. This is a fantastic quote that comes from a paper that I was part of, and this work was done by an amazing practice nurse in a town in Suffolk, and she just wanted to find out what it was about blue inhalers and adolescents. And she did the interviews, and she just had a fantastic connection with her patients, and they told her all sorts of things. And this was one of the fantastic quotes: "The blue one takes a battering. It really does. Not the best way, but it's the only way. It's just what you've got to do." And so the adolescents that she was interviewing, they were using their SABAs a lot. It was just extraordinary, the detail that she found it. They would use. There was one who was stopping during sex to use her salbutamol inhaler, really interfering with their lives. So yes, I think there is to some extent a problem with overuse of SABAs, particularly in adolescents and young adults. So there's good reason to stop. Next slide. So just from the primary care perspective, the new regimens that are being recommended, important because they do, the evidence shows that they do cut attacks and admission rates. I think what you should be doing is getting used to prescribing the new combination MART regimens. If you're not already doing it, your local ICB probably has got a chart of recommended dosage choices, and so it's good to look that up, because it'll give you guidance about what's recommended locally. If you haven't, then just look at what other ICBs are recommending, because it's an easy way to understand and to get into the habit of recommending this treatment approach. So if you've got someone who's certainly uncontrolled on what you might call traditional treatment, then it's a good opportunity to offer them this new approach. So think about that as an opportunity to get onto a more effective approach to asthma management. Next slide. This slide shows what I thought was a really nice decision aid, which you can Google. I think nice decision aid to climate conscious inhalers and green inhalers. Just search on those kind of terms, and you'll come up with a leaflet, and part of that leaflet is this handy chart that shows a bottom left-hand corner dry powder inhaler next to no CO2 consequences. MDI inhalers, top right there, are Symbicort inhalers. Using that's about the equivalent of driving a car. 115 mild. So there are big differences. And but the important thing to remember is there's no good prescribing an inhaler that a patient isn't going to use. If someone really needs to use the MDI to control their asthma, then that's got to be the better choice. Next slide. Just finally, some points about monitoring asthma and asthma control. The new guidelines say monitor asthma control every review. In addition to symptoms, check the following things. So time off work, school, how often are they using their reliever, steroids, courses, smoking, vaping. Always check inhaler technique. That's in the new guidelines. Consider using a validated questionnaire. Many people probably use the asthma control test already. It's easy to administer, simple results, easy to interpret, can give you a comparative measure of whether the patient with you is improving or not in terms of their asthma control. The Royal College of Physicians 3 questions, don't know if anybody uses those these days, but they're not recommended. NICE now says don't bother to use peak flow monitoring. I think a lot of us find peak flow monitoring quite helpful, but the recommendation is don't bother. And also consider exhaled nitric oxide monitoring at reviews and treatment changes. Next slide. So this, I think, is a really important point. Reviewing people after every exacerbation or admission. So, I'm sure a lot of people do this and understand the rationale. So it's an obvious chance to ask what went wrong and what should I change. So it's an opportunity to check about control, check inhaler technique, particularly give or review the asthma action plan, because we know that supported self-management and action plans work. I think this is the slide that I've just been talking about. I think we need the next slide, actually. No, it's not. No, sorry, go back. My mistake. Yeah, so yeah, and the final point here is flag patients at high risk. I do think that having a register or a flag for people who are at high risk of attacks and admissions is a really important point, because it just brings extra focus to that consultation. So I think the last slide, or next to last slide, shows some data, please. And this is data from East London. This was a study that was done in Tower Hamlets, and this intervention was an asthma specialist nurse linking up with practices and making sure that patients who'd been admitted or attended A&E had a high quality rapid review after their asthma attack. And essentially, there was a big effect here that showed that the time to the next asthma attack was extended in people who were reviewed swiftly and effectively after asthma attacks and admission. So this is something that can cut asthma attacks and cut admission rates to hospitals. So if you don't have systems in place for reviewing patients after hospitalization or emergency department attendance, then you should work to get these into place in your practice. Great. Next slide. I think it's the last slide. Oh yeah, I was asked to talk about quality of life, and I'm just going to go back to this paper that the nurse Sue Cole led on, and she got these extraordinary quotes which just showed how asthma blighted the lives and dreams of people in her practice. And they had grand plans, they had fantastic aspirations for what they were going to do with their lives. And so the one on the left here, it changed my life completely. I wanted to be a marine biologist, study sharks, PhD in sharks. I was diving, I couldn't use the tanks. And Sue says, well, what did you do? And the person says, well, nothing. I did computer work. It was just very uneventful. So the aspirations that she had, she didn't achieve. And on the right there, I would have gone into the army if I'd not had it. I really would have done. And there's lots of things I'd like to have done. At the back of my mind, I think I've got asthma. I can't. So, these are tragic, but surprising quotes from people who were just a normal practice out in Suffolk. These are not unremarkable people with asthma. And last slide. So this is a summary. Big opportunity through the new combination inhaler approach. No solo SABA tests to support diagnoses. Remember about asthma pollution. Ask during asthma reviews. Rapid reviews reduce asthma attacks and hospitalization rates. And climate conscious inhalers are an important option. So that's it. Hope that's been helpful.
That was fantastic. Thank you very much. I can see that there's been a fair amount of questions and chat stimulated in the chat, which is great to see. And we're going to come back to address the questions at the end. So do keep putting your comments or any thoughts or questions in there. Really, thank you, Chris. It was lots of food for thought, and I think really useful update for those of us working on the front line. What I suggest we do next is move on to Richard Chavas, who's our next speaker. And Richard's a consultant respiratory paediatrician at St George's. And he's just, are you there, Richard? Are you able to?
I'm here, yes. Can you hear me?
I can hear you. I can hear you. And now I can see you as well. Even better. Brilliant. Hi, Richard. Perfect. So are you able to share your slides so that we can see your presentation?
Good. Has that come up?
Fantastic. So I think we'll find out a little bit more about the treatment modalities of MART and AIR from Richard's presentation, which would be really helpful, and I think address some of the questions that have come up already as well. So thank you, Richard. Over to you.
Thank you, and thank you very much for asking me to join today. So I'm a respiratory paediatrician at St George's in South London, and just a bit of background. I worked with the BTS sign asthma guidelines for a number of years, but I haven't been involved more recently on the NICE guidelines. So just to put that into context, and just to pre-warn you, I have already lost contact with this meeting once and had to log back on, so I hope I will get through the next 20 minutes. And I'm going to talk today about MART and AIR therapy, just to go through some of the practical tips around that. The picture is of me, well, it's not me on a bike, but I have just been in the Alps and Dolomites for the last week, and a lot of that time it seemed to be skating on thin air, and thought that was quite topical. So just to start with some basic definitions, when we're looking at asthma therapy, obviously we all recognize the reliever or rescue treatment, the treatment that patients use for acute symptom relief, which may be before or after exercise or allergen exposure or whatever is making them wheeze. And then we move on to obviously maintenance or control or preventer therapy, and different people use slightly different terminologies and they may have slightly different connotations, but this is a regular or usually a regular treatment that reduces the underlying inflammatory process or underlying process that's driving the asthma forward to reduce the risk of asthma attacks and hopefully to improve symptom control. And this is typically an inhaled corticosteroid containing medication inhaler, but obviously as people with more significant symptoms go, there may be the need for additional treatments such as the leukotriene receptor antagonists and onto biologics and some combination of all of those different things. So moving forward to today's topic, so the first thing is AIR therapy or anti-inflammatory reliever therapy, and this is the use of a combination inhaler that contains both an inhaled corticosteroid and a fast onset, fast-acting reliever treatment in place of the single short-acting bronchodilator. And it's important to note that this is a fast onset long-acting bronchodilator, typically formoterol. It's not necessarily, or it's not appropriate to use one of the combination inhalers containing salmeterol, and there are good pharmacokinetic reasons for that, slower onset of action, so you don't get the same acute relief. And we're using these inhalers as that reliever or rescue treatment when a patient comes with acute symptoms. But air therapy can be used either as required as a standalone treatment at the sort of step 1 type stage of the guidelines, or as part of MART therapy, which we'll move on to now. So MART therapy is the use of a combination inhaler containing an inhaled corticosteroid plus formoterol or the fast-acting bronchodilator for both regular preventer controller doses, morning and or evening every day, and the rescue treatment. So the patient has one inhaler to cover all of their specific needs. As I said, they're morning and evening preventer doses, and then as required interval doses with symptoms. And why are we doing this? Well, Chris has already gone through most of these points, but we know that short-acting bronchodilator treats the acute symptoms of bronchoconstriction, but it doesn't sort out the underlying disease. We also know that regular short-acting bronchodilator and overuse is associated with adverse effects of the airway itself, which may actually increase airway hyperreactivity. It may drive eosinophilia, and overall you get a reduced bronchodilator effect from the medication due to sort of beta receptor downregulation. So the more you use, the less effective it's going to be. And it would seem, and there's evidence to suggest that overuse of short-acting bronchodilators does lead to an increase in exacerbations. And then, as Chris also indicated, actually the use of short-acting bronchodilator encourages patients. They get the hit from taking the short-acting bronchodilator. They become over-reliant on it, and they probably get less adherence with their preventer therapy. So we're not treating asthma in an effective way. And then, as Chris also indicated, many patients, or when we look at the fatal asthma attacks, many of those were deemed to have mild or moderate asthma only, so it's not just the severe patients. So patients may be getting missed by the standard therapy. So what does that mean comparing then and now? Well, it's sort of at the sort of lower step 1 of the guidelines, where we were previously suggesting salbutamol as required. We're now suggesting an inhaled corticosteroid formoterol combination on an as required basis, or in certain circumstances, although to me it doesn't necessarily make that much or adds a difficulty, you can take a separate low dose inhaled corticosteroid every time you take your short-acting bronchodilator. But obviously that's carrying 2 inhalers, and if we're talking PMDIs in children and a spacer, it kind of becomes more complicated. So looking at the combination treatment that may be best. And then when we're looking further up the treatment algorithm, where we're sort of suggesting a preventer inhaler, which may be an inhaled corticosteroid, or a combination inhaler twice per day, plus then salbutamol short-acting bronchodilator as required. We're moving towards the sort of MART type regime, using the same inhaler, inhaled corticosteroid formoterol combination twice daily, plus as required. So moving from the left of the screen towards the right. And what's the evidence? I'm not, I don't want to spend too much time going through all of the evidence today, but in young adolescents and adults, there's a lot of studies looking at MART therapy, and here's the sort of outcome of one review, and you can see that the red diamond shape as well to the left of the center line, indicating, favoring the combination of budesonide and formoterol, both reducing the or increasing the time to exacerbations and reducing the number of severe exacerbations. So there is clear benefit there. Now, most of those patients are in the adult age range, but there's enough evidence in the adolescents taken out of that to support that therapy in our patient group. And similarly, looking at the standalone air therapy, again, a number of studies, again, showing good support for using this treatment regime where appropriate in that age group. And then in the 6 to 11 year group, again, there's historic data going back a long time actually showing some benefit to using a MART regime in children between 4 and 11 years of age. And this was a study that compared the use of budesonide formoterol as a daily maintenance plus additional doses for symptom relief compared to just a fixed use of the combination inhaler plus salbutamol or fixed dose budesonide plus short-acting bronchodilator as required. And the top graph in the middle there, you can see that the SMART regime reduced the risk of severe exacerbation quite significantly. There has been issues, and there still are some issues about the licensing of PMDI containing combination inhalers suitable for younger children, which is perhaps why this didn't take off at an earlier stage. And then on the right-hand side of the screen, looking at air therapy in the 6 to 11 age group, there's relatively little evidence for ICS-LABA at the present time, but the sort of TREXA study by Martinez back in 2011, which compared BDP both as regular and rescue, regular treatment on its own, or rescue on its own versus placebo, there was certainly evidence within that suggests that the BDP on its own was better than SABA alone. But there needs to be a little bit more work in this area to fully support the use of widespread air. But it is coming out in the, I believe, in the NICE guidelines. And then looking at the GINA guidelines from 2024, so the latest iteration of that this shows now where they are suggesting that we sit. And so the preferred track, the middle orange bar there, is using the controller plus reliever so the combination ICS formoterol. And at steps 1 and 2, they're suggesting that we use this is 12 and above, using that on an as-needed dose only, so that the patient takes their combination inhaler as required. And then if their symptoms, they're having still lots of use or breakthrough, then you move up into the MART-based regimes with once or twice daily preventer doses plus ICS formoterol as required. And when we look at the children 6 to 11 years, again, their preferred regime is low-dose inhaled corticosteroid taken whenever SABA is taken. So using 2 inhalers, again, this is because of the difficulties. And then as you move up towards step 3, where we're ending up at SMART, so slightly different tracks, but a similar ethos. And then obviously there are a number of combination inhalers that are used or usable in this. As I said right at the start, these are still typically containing formoterol rather than salmeterol because of the pharmacokinetics, and not all are licensed for children at the present time. We have obviously Symbicort in Turbohaler as a product, either at 100/6 or 200/6. there is a Symbicort PMDI.
Just click on that. Yeah, there's a send link and downloads automatically onto the computer.
Excuse me. Symbicort PMDI, which is a lower dose with a lower dose of the formoterol. So that may change or does change the dosing requirements. And we've got Fostair and Walker. I mean, my advice is that we and my practice is I try and get good at using one or two different inhalers and use those the majority of the time, obviously working with the patients to make sure that they can take these devices effectively. And obviously the dry powder devices, when we're talking about children, do require that additional or extra inspiratory force to be able to take the inhaler effectively. So you have to spend time to make sure that they're capable of taking these devices properly. There are a number of other inhalers listed at the bottom there, which presently, to my knowledge, haven't got licenses for children under 18 or young people under 18, but obviously that may change over time. And the doses within them are equivalent despite the numbers mentioned there. So on this slide, as I said before, it goes through the steps. So steps 1 and 2, as needed, low dose ICS formoterol reliever. The person has one inhaler which they can use on an as required basis. At step 3, they can go to low dose maintenance therapy, so initially once daily and then twice daily, with additional doses as required. And then step 4 is increasing the maintenance doses up to 2 inhalations twice a day. And again, this goes through the typical regime. So with the MART regime, you have one or two puffs once or twice per day as the preventer at the level that gives the best control. And then if the person is symptomatic, the dose for the rescue treatment. And this differs significantly, obviously, from what we're used to using with the blue inhaler, but we ask them to take one additional puff of the combination inhaler. If their symptoms don't settle quickly, they may repeat that after 1 to 3 minutes. And the maximum is 6 puffs in one dose. So if they're tight, they take a puff, their symptoms don't settle, they take a second puff, the symptoms still not settling, third, and so on and so forth, to a maximum of 6. If their symptoms are controlled, they have a maximum of 12 puffs within this regime within a 24-hour period. So that includes the 1 or 2 puffs twice a day maintenance dose, up to 12 puffs within a 24-hour period. And for younger children than 6 to 11, it's reportedly 8 puffs within that 24 hours. So you have to be careful around the maintenance, the numbers of puffs. And then what we need to do, and I think still there is debate around, but if a person is needs to have 6 puffs in a single dose to settle their symptoms, they need urgent assessment. And to me, that's, we're dialing 999 at that point in time. If they're needing, on one day up to 12 puffs, they need to have that assessment, an urgent assessment required, and some of the 8 puffs in the children. So these are our sort of threshold points, and that I think we have to learn, and we have to build into the way we're thinking around this. But the hope is that this is rare, and that the control that is provided is good enough that this becomes a less frequent thing. But for sure, we're still going to get interval symptoms and acute attacks. And then obviously we need to give all of our patients a working asthma action plan. And this is the Asthma and Lung UK MART-based plan. So it's different from the standard treatment, the standard plan that has been used with a separate maintenance and reliever treatments, but it is all there, and you can go down through the list. You can put in the name of the inhaler that they're taking, how many puffs they're going to take in the morning, how many puffs at night, what is the maximum number of puffs in a day, so as I said before, up to 12 for adolescents and adults, and then what to do when they're feeling worse. And it goes down through the list of how many puffs are required. We are in London looking at, and for the pediatric side, we developed asthma action plans for standard therapy for 4 to 11-year-olds and 12-year-old plus in the sort of child section. We are trying to develop a MART-based plan that looks similar to those things, and that hopefully will be released later on this year. There is some advice in there as to what to do during, a more severe asthma attack and what to do when you've called 999. So hopefully that will be helpful. So hopefully that's given you a bit more of an understanding about and MART therapy, when to use it and why, and how to use it and why. And as I say, I think there's a lot we need to reflect on as clinicians. We've got to be confident with the plans that we're putting forward. We have, and we have to be consistent with that, so that families and young people can be reassured that they're doing the right thing. And the other sorts of areas where it's important is, if we give them a blue inhaler as well, then they will continue to resort to using that because that's what they've been used to. So it's being consistent along those sorts of lines. As I say, I think there are some limitations in the 6 to 11 group, but hopefully as combination PMDIs become slightly more available, and we can gather more evidence, and there are hopefully studies going on at the present time that will give us more robust data in that age group. Hopefully we're in the right place moving things forward. So thank you very much for listening, and we'll happily get together and take some questions. I'll stop sharing my screen.
Thank you, Richard. I think you answered lots of the questions that have come up before, and you prompted lots of new questions. So lots of engagement in what you were saying. I think it was, really relevant content to everybody. I can see that there's a couple of people with hands up. I don't know if you were wanting to address specific points. I think most of the questions we're going to address have come from the chat, and we're going to try and put those to Chris and Richard to see if we can sort of sort out some of the key things that have come up. If it's all right, I'll start by addressing those, and if there's any other points that people particularly wanted to mention, do pop them in the chat, and we can add those in. So going through the questions, one of the first questions that came up was, at the moment, QOF requires surgeries to diagnose on spirometry and or pheno or peak flow. Will this change? Sometimes this leads to delays in treatment. Chris, have you got any knowledge about how the sort of GP practice processes and QOF processes and demands are fitting in with the changes in the guidance? You're on mute, Chris.
So again, yeah, sadly not. I'm not involved in the, thankfully, in the process to to update QOF. So I don't actually know the answer to that. But you would expect that if there is a credible change to the guidelines, that it would be reflected in the QOF requirements. So I suppose it depends how those people involved in QOF view this particular change in terms of its credibility. So I'm sorry, I don't know the exact answer to that.
Okay, thank you. Yeah, and from my point of view, I don't have an answer either to that, except to say that the guidance is draft at the moment. So until it's published in full, I doubt other sets of criteria like QOF will change to reflect it. So we have to watch this space a little bit. It's a little bit frustrating, the middle ground that we're in at the moment. So next question, if we have Pheno and Spiro available in surgery, do we do both sets of tests or just Pheno? And I think this is a similar theme, really. And as I say, I think the current guidance that's in place and what the QOF criteria wants is it wants us to do both, right? So as we stand at the moment, the active guidelines are to do both, but it is likely to change if the draft guidance do go forward in their current state, which suggests just doing Pheno. So I think we just need to watch this space for the answer to that question, I'm afraid, at the moment. So a question from Bartolomeo Accardo. Do you agree that peak flow is still a useful tool in monitoring that can also be used in diagnosis? Don't you even measure peak flow when on MART? And I think there are quite a few questions I noticed in the chat about peak flow, actually, about its usage and whether this new guidance is saying don't use it just for diagnosis, or is it saying don't use it for monitoring at all? And what is the basis, the sort of evidence base behind that change in guidelines? Richard, have you got any thoughts about the use of peak flow going forwards?
So I have to say, I have never been a great fan personally of using it as monitoring for, across the sort of group of patients that I care for. And I know I'm a little bit outspoken around this, but I find that, many people don't do it regularly enough, don't do it properly. And sometimes we're slightly misled by that. But I also know many of my colleagues are bigger fans of it. I find it really tricky. I think that there are certainly patients where we know that they, are not great symptom perceivers, and sometimes using peak flow or something similar may help them understand their physiology a bit better. And I think that would be useful at that time. I think where we've had this void in the diagnostic capabilities, particularly in primary care, being the absence of Pheno and or spirometry across the board for children and young people, using peak flow, for a 2 to 4 week period, may help with diagnosis. So I think that there's certainly a role for it. It's just where it sits. But personally, do I monitor all of my children all of the time with twice daily peak flows? I'd say no is the answer to that.
Thank you. And I see Chris was had his hand up there as well.
Yeah, I mean, I think it's a bit anomalous if we are recommending peak flow guided action plans and yet not recommending ourselves to use peak flow to monitor asthma control. I don't actually know of a breakdown analysis that split self-management plans. I'm sure it has been done. How effective are self-management plans guided by peak flow versus symptom-guided self-management plans? I'd have to look that up. I'm sure that analysis has been done. But on the assumption that peak flow guided self-management is effective, then you would think that suggests that using peak flow to judge the way to manage your asthma is a helpful thing. So that strikes me as an anomaly.
Yes, it's interesting. And again, let's see, I suppose, what form that comes into in the final guidance. I did cut and paste the quote from the guidance into the chat, which says Don't use peak flow regularly in monitoring, but it does say that there may be patient-specific reasons to do so, and Richard touched on those earlier. But it's something to think about, isn't it? About if it is in all the action plans, then we need to make sure patients are aware of it, don't we? So we need to be a bit consistent somewhere in there. So it'd be interesting to see what comes through in the final guidance. Moving on, because there's also a lot of questions in the chat about MART regimes for younger children and which inhalers are licensed. So from Lara Govindan, should children and young people be changed to MART even if they are currently well managed on their inhaled corticosteroids alone? So that's the first question.
So I think my answer to that is, you know, we need to assess, you know, all of our patients ongoing, and we have a discussion around treatments ongoing. And so where someone is really settled on treatment, you know, is there a case to rock the boat? Not necessarily, but I see, you know, children as they grow into adolescents and young adults, their, you know, preferences will change over periods of time, their you know, adherence to treatment will change over periods of time, their confidence of, you know, the green debate and those sort of things change over a period of time as well. And so all of these different things, you know, are important to discuss when we see people and assess. And therefore, you know, I suppose in my practice, I would talk to, you know, those patients as they come through and decide whether we do try alternative therapies and, you know, use a MART-based treatment. You know, it may take them away from using a PMDI with a spacer, and I will use a spacer with every child with a PMDI. So you know, they can take their treatments more discreetly or whatever, and we get the benefit of switching to the MART regime. So I think it's an important conversation to be had when you have your annual reviews or at other reviews in between times.
I think that was a really helpful answer, and of course it's a reminder to everyone that the you know, the basics in asthma management are the most important things often, aren't they? It's about the conversations with the patients and the regular reviews and the inhaler technique and everything else. Another question that I think has been asked a couple of times in the chat is about whether when someone's on a MART regime, should they also have a SABA inhaler for the scenario where they get into the red zone on their asthma plan and they need emergency treatment, SABA being the salbutamol or terbutaline inhaler.
Yeah. So again, if I can just come back on that, I think when I first started using MART, and my use has increased, I would say almost exponentially over the last sort of couple of years or more. I would leave people with a blue inhaler in the cupboard. But I guess what I found is that people would sneakily resort back to that or use a bit of both at the same time. And therefore we're not using the MART regime as effectively. So as my confidence has grown in using MART, I am now subtly not giving them or taking away, if I can, the blue inhaler. So if you like, that there's kind of less chance that they will veer from the course that we've set. Clearly, again, on an individual patient basis and with discussions and so on and so forth, to make sure that they're all on board with that. And you know, I think that's where it comes into with some consistency, because, you know, dare I say, what we find is that we'll advise a course of treatment in secondary or tertiary care, and things may then get adjusted slightly in primary care, and then we get the sort of difficulties with families understanding exactly what's going on. So, and that's confidence of practitioners across the whole health spectrum.
Okay, I think we're going to run out of time very soon. There was one other question that I wanted to highlight just because it was something that came up a couple of times, which is about whether MART is recommended in under 12-year-olds, and if so, what inhalers are licensed for that. And also which types of inhalers are licensed in the 12 to 18-year-olds, because not all of them are they? I don't know if either Chris or Richard have a quick answer to that question.
So I think I put in my slide, sorry, that there are some combination inhalers that are licensed for the younger adolescents and into adulthood, whereas there are some that are still adult only. So my preference would be to use those that are licensed. There is the Symbicort PMDI 100/3 that's, I think, becoming more available, but there has been a limitation, and I'm going to be completely honest and say I'm not sure whether that has a full license at the present time, but I think it's going to be included within the NICE guideline. So we'll perhaps have to wait that space. And as I say, and I think I saw one comment sort of saying that there's a study going on to give us more evidence, which will hopefully help licensing going forwards for MART in the 6 to 11 age group.
Yeah. Thank you. I think somebody's put in the chat that there is one combination inhaler licensed for 6 to 11-year-olds at the moment. But I agree with you, Richard. I think once we get the final guidance, it will hopefully be much more clear which inhalers are recommended for which age groups. Well, the time has ticked over 2 o'clock. What I'm going to suggest is that I know there have been so many really fantastic questions, and perhaps we can try and go through and see if we can answer any outstanding ones in the chat after the event. But the recording will be available and the slides will be available for you to receive by email afterwards. So do go through any information and see if questions are answered there as well. It would be fantastically helpful if all participants could fill out an evaluation form at the end of the session, which has just been popped in the chat. It takes about 1 minute, and it's really helpful to the team at Ask About Asthma in planning future events. Thank you so much to Richard and Chris, and to all the team in the background who've planned the event today.
Thank you.
Thanks a lot. Thanks, Rosie.